Thank you so much. And thank you for the audience that's coming in very early morning. I think it's difficult. That's this session. Firstly, we should know what is the problem of keratoconus. So we have mainly two problems. Disease progression, so we have to stop this progression, and the visual impairment, so we should treat the irregular corneal surface and treat or any associated refractive error. Although there's many alternatives of management of keratoconus from non-interventional management like spectacle correction contact lens, we have many interventional management from PKB to DULC to cross-linking to the intraocular lens and combination of all. It's very important us to build up our protocol in keratoconus, so the stability of visual rehabilitation is very important together. Of course, the stability by the cross-linking is not debatable, but the visual rehabilitation is very important. And if have a refractable vision, reasonable best corrected visual acuity, together with the stability, we can have another options away from DULC or PKB, which is refractive solution of keratoconus, like IOL implantation, whatever it's phakic or aphakic, PRK with the cross-linking like FM protocol. And it's very important thus to determine the stability and the progression of the case. In intraocular lens implantation, it's very important to have three reasons. One, for the spherical equivalent, it's more than -6, reasonable visual acuity, which is very important, and of course the stability of the vision. When toric ISL implantation in cases of keratoconus, I think recommend the criteria. It is the same as any recommendation according to the age, to the best corrected visual acuity, stability of the vision, clear cornea, and EC depth not less than 3 millimeters with normal IOP. And the exclusion criteria away from the normal exclusion criteria of the keratoconus, if it has a progressive keratoconus, best corrected visual acuity less than 20/60, high astigmatism or highly aberrated eyes, of course it is not a suitable case for ISL. The key point of the success is to have verification of the power together with the power of the exact axis of the cylinder in this case. And we have special tips and tricks that's to have refraction in keratoconus. It's very important that's to have a cycloplegic refraction, accurate subjective refraction with the lowest sphere and cylinder that they give the best corrected visual acuity. The exact axis, which is not an easy solution, because that should be determined by all available optometric tricks. 3 consecutive monthly visits, at least at 9 months after stability of the vision with the cross-linking, to be sure of stability of refraction. And of course that we should encourage the patient to wear glasses at least 1 month before any procedures. According to the visual refractive outcome in all literature of the toric ICL, it is somewhat debatable, but it gives a good result in some selected cases. But we should know that the phakic ICL, it's somewhat expensive, especially in low socioeconomic standard, and the temporary solution, as after approaching the patient to 40 years old, that's loss of accommodation, and we can remove the ICL together with the lens of the patients. So the idea started in 2015 in the Society of Ophthalmology, when that's present a case of refractive exchange with a spherical IOL implantation in some selected cases of keratoconus, 12 eyes aged more than 40 years with a spherical equivalent to high myope more than -10 diopter with low cylinder. And of course, just clear lensectomy in such these cases and the myopia can that improve the vision, either uncorrected corrected visual acuity with marked reduction of the sphere and cylinder, and highly significant patient satisfaction. Then after this, we publish a paper about objective subjective outcome of clear lensectomy with toric IOL implantation in selected cases of keratoconus. We have 9 progressive keratoconic patients with a spherical equivalent from -6 to -12 diopter with slender up to -5, best corrected at least 680, and the sphere and cylinder ratio, it is 3 below than 3 to 1. Pre and post-operative measurement parameters were very satisfying for the patient, either the corrected visual acuity, contrast sensitivity, the glare, the Kmax. And of course, all subjective parameters like clarity of the vision, glare, halo, visual rehabilitation, activity limitation, far or near spectacle dependence, it's a highly significant result before and after. And this is one of the cases, a 41 years female, progressive keratoconus was stabilized by cross-linking, and with this refraction, with Kmax 56, and cornea thickness, of course, not suitable for ICR. And this is the refraction of the patient. So the second day, it's been very surprising to be, it's only this refraction with 6 nines unaided. And thanks for this article and review articles that to cite my paper in surgical option for refractive correction of keratoconus. But of course, the toric IOL is debatable in keratoconus because it may fail to neutralize the irregular portion of the corneal astigmatism. High order aberration by keratoconus not corrected by the IOL. It's very difficult to determine the exact axis. It is not always the same as like this case, and maybe it is required to change sometimes the toric IOL or combine this with ICR or anything that can regularize the cornea. So this is why we make the second paper, two-stage procedure in management of selected cases of keratoconus. We have clear lens extraction followed by aspherical IOL implantation and wavefront PRK. So in the visual and refractive parameter of such studied cases, pre-operatively and post-operatively, it's very encouraging. Also, the aberrometric and mesopic vision, highly significant reduction, with all subjective parameters increased after this procedure. And this is before and after. So the wavefront guided PRK in such this case can high capability of aberration measurement, can regularize the cornea with flattening the cone, not only a refractive, but it gives a stability of the topography. And wavefront treatment as a refractive procedure has also a therapeutic one. And this is the case 4 years post cross-linking with clear lensectomy with monofocal IOL. And it's very surprising when come to my clinic for the second procedure. The patient was very, very satisfied without PRK due to marked flattening of the cone after the cross-linking. And also that's combined by clear lensectomy, and the patient's very satisfied and not need any further procedure. The PRK with cross-linking is still debatable and have a big thinking, but it's very important as to know, again, should be stability of the vision with refraction. It's not more than calculated appellation, not more than 50 micron, and after laser, you should not leave less than 350, and with asymptomatic patient with a glare and contact lens intolerance. And in this paper, that we encourage that simultaneous versus sequential accelerated cross-linking, and although it is a debatable result, but it might make the same cases, but I prefer this to make sequential cross-linking, the PRK after cross-linking, after flattening of the cone at least by 1 year. So I think although the keratoconus was once considered contraindication of refractive surgery, but have many refractive procedure now safe alternative for keratoplasty, and should be tailored with HI to hold the disease progression and to provide rehabilitation when minimizing tissue removal. And I think controlled randomized studies with larger coherent and longer follow-up periods are needed to determine the refractive procedure suitable for this case. Thank you so much.